Could you imagine having to choose between unbearable surgery and certain death? For most patients, before the mid-1840s, that was the reality of major surgery. There was no reliable, widely available way to make the pain disappear. Just a knife, a table, and whatever willpower you had left. Let's step into that world for a moment. Picture a small village in the early 1800s. A farmer's arm has been shattered in an accident, and the wound has started to blacken. The physician doesn't sugarcoat it. The limb likely has to come off, or the infection could spread and threaten the whole body. Operations like this weren't taken lightly. They were usually reserved for situations where the alternative seemed to be death or permanent severe disability. Historical accounts describe patients who refused the knife entirely, choosing to take their chances rather than face the table. Others agreed, then had to be half carried in when their nerve failed at the last moment. Inside the operating theater, major teaching hospitals often perform surgery in rooms called theaters, or surgical amphitheaters, because they were designed for observation and teaching. Amphitheaters like the famous Ether Dome at Massachusetts General Hospital were often built with large skylights, because reliable artificial lighting was limited, and surgeons often relied heavily on strong daylight. Tiered benches let trainee doctors and students watch and learn. Patients might be given alcohol or opium beforehand, which could dull the senses somewhat, but neither came close to eliminating surgical pain. In many operations, assistants were on hand to help hold a patient still, since even a willing patient's body would instinctively fight against the blade. Speed as a priority. With no reliable way to erase the pain, speed became one of the most valued skills a surgeon could have, though not the only one. Technical precision, minimizing blood loss, and overall outcomes mattered too. Still, a faster operation generally meant less time in agony and less physiological strain on the patient. Some surgeons of the era, including the famous London surgeon Robert Liston, became renowned for performing amputations with extraordinary speed, sometimes reportedly in just a few minutes. Mortality from these operations was high, though the exact numbers varied enormously depending on the hospital, era, and type of procedure. This isn't a case where one single statistic tells the whole story. Surviving the operation itself didn't guarantee survival afterward. This was an era before germ theory was understood or accepted. Surgical clothing wasn't routinely sterilized, and blood-stained coats were sometimes seen, perhaps surprisingly, as a mark of an experienced surgeon rather than a hazard. There was no modern system for sterilizing instruments between patients. When pus appeared in a healing wound days later, physicians of the time often took it as a reassuring sign, calling it laudable pus. In reality, this frequently signaled infection setting in. Post-operative infection was a major cause of death in this era, and rates varied significantly by hospital and time period. One physician, Ignaz Semmelweis, found that doctors washing their hands between patients dramatically reduced deaths from infection. His findings were met with resistance and skepticism from much of the medical establishment of the time, who found the idea uncomfortable. Semmelweis died in 1865 after being committed to an asylum, his work still far from universally accepted. A complicated and somewhat tragic end to a career spent trying to prevent exactly the kind of death he had worked so hard to explain. But then, one October morning, something happened that would change surgery forever. On October 16, 1846, at Massachusetts General Hospital in Boston, dentist William T.G. Morton publicly demonstrated the use of inhaled ether to produce surgical anesthesia, delivered through an inhaler he had designed. Surgeon John Collins Warren then operated on the patient, Edward G. Abbott, to remove a tumor from his neck. It became one of the most celebrated public demonstrations in the history of medicine. Morton wasn't technically the first to use ether this way. Physician Crawford Long had done something similar back in 1842, but Long hadn't published his findings, so it was Morton's Boston demonstration that made the technique famous remarkably quickly. Popular retellings often claim the patient reported almost no pain at all, though some historical accounts suggest Abbott was at least partly conscious, and later described the pain as considerable but mitigated, more mixed than the simplified legend implies. Either way, news of ether anesthesia spread to Europe within a couple of months, and surgeons on both sides of the Atlantic began adopting it. Not everyone welcomed painless surgery right away. Some physicians argued that pain served a physiological purpose during an operation, and there was real resistance in some medical circles to adopting the new anesthetic agents. Others viewed the ability to endure pain as tied to notions of character. Public perception shifted further when Queen Victoria used chloroform, administered by physician John Snow, during childbirth in 1853 and again in 1857. Her example is widely credited with helping normalize obstetric anesthesia, though historians caution against treating it as the single moment that ended all resistance. Acceptance grew gradually rather than overnight. Infection remained the deadlier problem for a couple more decades, until surgeon Joseph Lister began developing and applying antiseptic techniques with carbolic acid in the mid-1860s, gradually helping bring down post-operative death rates as the practice spread, though adoption varied by hospital and country. Why this matters today. Every time someone goes in for surgery now, put under anesthesia, and waking up afterward in a recovery room, they're experiencing something that simply wasn't available to most of human history. The patients who once had to be held down on operating tables would likely find modern surgery almost unrecognizable. Modern anesthesia didn't eliminate surgical risk, discomfort, or recovery altogether, but it did remove something that used to be unavoidable: the requirement to be fully, helplessly awake for it. That shift, which began in the 1840s and accelerated through the following decades, is one of the more remarkable turning points in the history of medicine. If you had lived in the 1800s, would you have risked the surgery or refused it entirely?